Hello, and thank you for participating in the BC Technical webinar series. We will be discussing a literature review of combined acquisition for 18F fluoride and 18F FDG images, a cocktail approach. Today's webinar session is worth 1 voice credit. In order to receive this credit, you must complete the online test, which will be available immediately after this webinar. A passing score of 80% is required for the voice credit to be awarded. You may take the test more than once if need be. A certificate will be emailed to you at the close of this webinar and following successful completion of the online test. Please keep this certificate as proof of your completion of this webinar. New and interesting approaches to imaging are occurring daily. So why would anyone be interested in this imaging method? Improved patient care, medical facility workflow, and reduction in costs may be the result of this research, in which it may be possible to combine 2 imaging procedures into one. This new cocktail approach to performing oncology imaging has the potential to reduce patient radiation exposure and total procedure time of about 8 hours over a 2-day period to about 2 hours total. The full benefits of this research are still unfolding. We will be covering the following topics. First, we will look at the proposed benefits of using the cocktail imaging approach. We will then look at the background of using 18F labeled FDG and 18F labeled sodium fluoride for oncology PET. We have several image examples, which will be followed by Stanford University's preclinical trial methods and materials. We will then take a look at the initial processing example and Stanford study results. Continuing with the overview of topics, there are some author-acknowledged study limitations that we will outline. This will then be followed by one slide showing the effects of post-marrow stimulation. And next, we will look at an international study recently completed by looking at the methods, materials, and trial results. Completing the overview of topics, we will review images from the international trial. And lastly, we will outline the University of Missouri's follow-on cocktail ratio study. Imagine if the following possibilities could come true. If 2 diagnostic procedures, each done on different days, could become one combined procedure. If patient procedure time could be reduced from about 8 hours to less than 2 hours. If the total radiation exposure could be reduced by using only the one combined procedure. If the total costs and expenses could be reduced for both the patient and the insurer. All of these possibilities are one step closer after Stanford University's pilot phase study, which used a cocktail of 18F fluoride and 18F FDG for PET-CT scans to evaluate malignancy. Let's begin by looking at the background of 18F oncology imaging. The use of 18F FDG PET-CT is a proven imaging method for a variety of cancers. However, due to the variable rates of glucose metabolism, not all malignant lesions are readily identified. Currently, initial staging uses both routine images with 18F FDG PET-CT and technetium-99m MDP bone scintigraphy. However, 18F fluoride by itself, which is a positron emitter, provides excellent quality bone scan images. So the next logical step is to combine 18F fluoride and 18F FDG into a single study for bone and soft tissue. Continuing with the background, Using this technique, there is potential for improving diagnosis, improving staging, and possible therapy monitoring. To test this possibility, in 2008, physicians and other researchers at Stanford University evaluated the feasibility of injecting a cocktail dose of 18F fluoride and 18F FDG for a combined scan. Let's take a look at a couple of image examples. Shown here is an 18F FDG PET maximum intensity projection image, or MIP. It shows an abnormal 18F FDG PET scan. Cancer cells are metabolically hyperactive compared to healthy cells. PET imaging with 18F FDG will show areas of this increased metabolism as hotspots on scans because these areas of increased metabolism, which are usually tumors, use glucose as energy. This patient has multiple hotspots and, as a result, multiple abnormal areas. Shown here is an 18F fluoride PET bone scan shown in the MIP projection. PET imaging with 18F fluoride has been shown to provide superior functional imaging of the skeleton. Again, this patient has multiple areas of abnormality, and those are shown as hotspots. Let's take a look at Stanford's preclinical trial methods and materials. 4 mice underwent 3 PET scans on separate days. Scan 1 was a PET 18F fluoride bone scan using 200 microcuries. Imaging began 1 hour post-injection. Scan 2 was a PET 18F FDG whole body scan, also using 200 microcuries. Again, imaging began 1 hour post-injection. Scan 3 was a combined 18F fluoride and 18F FDG scan using 100 microcuries of each isotope. Imaging began 1 hour post-injection of the cocktail. The PET images were acquired using a micro-PET rodent R4 scanner from Concord Microsystems. CT images were acquired after scan 3 only using an Explorer RS micro-CT system from GE Healthcare. After the scans, processing required the following: reformatting the CT image to PET image dimensions, removing the bed portion of the CT image, thresholding the CT image to keep bone structure densities and eliminate soft tissue structure densities, multiplying the PET image by the mask, resulting in a bone image with combined 18F fluoride and 18F FDG uptake. This preclinical trial provided proof of feasibility for a follow-up pilot clinical study. Now let's take a look at Stanford's clinical trial methods and materials. The clinical trial included 14 patients consisting of 3 women and 11 men, ages 19 years to 75 years. The diagnosis included prostate cancer, soft tissue sarcoma, breast cancer, osteosarcoma, colon cancer, lung cancer, and malignant paraganglioma. Each patient had 3 separate scans within a 2-week period. The scans were an 18F fluoride PET-CT scan first, then an 18F FDG PET-CT scan, and finally a combined 18F fluoride and 18F FDG PET-CT scan. Continuing with the clinical trial methods and materials, the whole-body PET-CT images were acquired and reconstructed using a Discovery LS scanner from GE Healthcare. The images were reformatted and reviewed on an Accelerus workstation from GE Healthcare. Injected doses were 10 millicuries for the 18F fluoride bone scan and 15 millicuries for the 18F FDG whole body scan. The combined scan used a ratio of 1:3 for 18F fluoride to 18F FDG, resulting in an injected dose of 5 millicuries for the 18F fluoride bone scan and 15 millicuries for the 18F FDG whole body scan. The CT scan matrix of 512 by 512 was downsized to match the PET scan matrix of 128 by 128. CT data from the combined scan was used to create a bone mask that allowed the display of 18F FDG PET-CT in the bone structures on the PET scan. The scans were independently interpreted by 2 board-certified nuclear medicine readers, and each detected lesion was compared using all 3 scans. Shown here is an overview of the steps taken by the Stanford researchers to create the bone mask image. Reference Image A. The first step is to reformat the CT image to the dimensions of the PET image. Reference Image B. Using software, the CT table or bed is eliminated by indicating the most dependent part of the body as the image limit. Reference Image C. The CT image is interactively thresholded to eliminate all soft tissue, but keep bone densities. And reference Image D. The PET image is multiplied by the mask, leaving a bone image with combined 18F and 18F FDG uptake. Comparison of the combined study to the 18F fluoride bone scan yielded these results. The combined scan results were comparable to the 18F fluoride PET-CT bone scan. Thus, the combined scan is feasible for pre-therapy evaluation of known malignancy. The visual analysis of the combined scan without processing also compared favorably with the 18F fluoride PET-CT scans. There was no reader disagreement. However, there was one skull lesion seen on the 18F fluoride scan that was missed on the combined scan, with no patient management impact. The next slide shows these images. This slide shows a comparison of 18F FDG whole body scans, 18F fluoride bone scans, and the combined 18F FDG scans. These images are of a 44-year-old man with soft tissue sarcoma. Image A is the MIP image of the 18F FDG whole body PET, showing normal radiotracer uptake. Normal 18F FDG uptake will be shown in the brain, kidneys, and sometimes the myocardium. Image B is the MIP image of the 18F fluoride PET bone scan, showing intense radiotracer uptake in the skull lesion, which is marked by the arrow, and in the T10 vertebra and right pubis, marked by the arrowheads. Image C shows no skull lesion on the MIP image of the combined 18F FDG, but does show the skeletal lesions in the T10 vertebra and right pubis, noted on the 18F PET bone scan, each marked by the arrowheads. Image D shows the skull lesion as seen on the transaxial CT scan. Image E shows the same lesion on the 18F PET bone scan. Image F, the combined 18F FDG scan, does not show the lesion. Image G shows the lesion in T10 vertebra on the CT transaxial. Image H shows the same lesion on the 18F PET bone scan. And image I shows the same T10 lesion on the combined 18F FDG PET whole body scan. These three images show extensive disease in a 68-year-old man with colon cancer. Image A is the MIP of the 18F FDG whole body PET, showing faint radiotracer uptake in several skeletal lesions. These are marked by the arrowheads. Image B is the MIP of the 18F fluoride PET bone scan, showing intense radiotracer uptake in multiple bone lesions, including better visualization of lesions seen on the 18F FDG whole body PET, marked by the arrowheads, and more extensive skeletal metastases marked by the arrows. Image C is the MIP of the combined 18F fluoride and 18F FDG PET scan, showing skeletal lesions marked by the arrowheads, which are also noted on the 18F PET. Comparing the combined study to the 18F FDG whole body scan yielded these results. For all patients, visual analysis between the two scans were identical. No lesions were missed by combining the procedures. The combined scan allowed for accurate interpretation of soft tissue uptake, as shown on the next slide. There was no disagreement between the readers. These three images are of a 75-year-old man with prostate cancer. Image A is a MIP of 18F FDG whole body PET, showing lymph node metastases, marked with the arrowheads, and faint uptake in osseous lesions, such as the right rib, marked by the arrow. Image B is a MIP image of 18F fluoride PET bone scan, showing intense radiotracer uptake in multiple bone lesions, including the right rib lesion, marked by the arrow, also seen on the 18F FDG PET. Image C is a MIP of the combined 18F fluoride and 18F FDG PET, showing both lesions noted on the 18F FDG PET, marked by the arrowheads, and skeletal lesions noted on the 18F fluoride PET. Note the right rib lesion marked with the arrow. In this pilot phase study, where there were some author-acknowledged study limitations, the sample size of 14 patients was small. There was selection bias towards patients with known cancers. Interpretation of the three different scans was not totally independent due to the short interval between each scan. The bone mask technique has the limitation of possibly including contiguous soft tissue disease as part of the skeleton. And none of the patients received colony-stimulating factor therapy, which produces intense bone marrow uptake and could possibly cause issues with accurate interpretation of the combined scan. See the next slide for an image example. This is an image of an 18F FDG patient after receiving colony-stimulating factor therapy. The marrow stimulation resulting from this therapy produces intense 18F FDG skeletal uptake, making accurate interpretation of combined 18F and 18F FDG scans confounding. Let's continue with a look at the international Prospective trial. An article published in the European Journal of Nuclear Medicine in 2012 showed the continuation of this method by further study and a prospective comparison of 62 patients. This study was also conducted by researchers at Stanford University and researchers at Apollo Gleneagles PET-CT Center in Hyderabad, India. The international Prospective trial compared the clinical usefulness of a combined 18F fluoride bone scan and an 18F FDG PET-CT whole body scan. Additionally, it investigated whether the combined scanning will be performed in sequence with delayed administration of 18F fluoride subsequent to the initial 18F FDG injection. Now let's take a look at the international Prospective trial methods and materials. First, all patients were scanned at the Apollo Gleneagles PET-CT Center in Hyderabad, India. Patient scans were then transferred to and analyzed at Stanford University in Palo Alto, California. All cancer types were included in the study in order to simulate actual clinical experience. All scans were acquired on a Siemens Biograph 16-slice PET-CT scanner. Images were displayed and interpreted on a dedicated workstation using Accelerus software from GE Healthcare. There were 62 patients enrolled in this prospective trial, ages ranging from 22 to 74 years of age, with an average of 52.6 plus or minus 12.7 years. There was an almost 3-to-1 ratio of women to men. All patients received both an 18F FDG alone PET-CT bone scan and a combined 18F FDG and 18F fluoride PET-CT whole body scan. 53 or 85% of the patients received simultaneous tracer injections. 9 or 15% of the patients received 18F fluoride subsequent to the initial 18F FDG dose, with an average delay of 2.2 hours. Images were independently reviewed for PET findings by 2 board-certified nuclear medicine physicians, with discrepancies resolved by a third reader. Continuing with the trial methods and materials, the injected doses were as follows: 15 millicuries for the 18F FDG whole body scan, and for 85% of patients, simultaneous 5 millicuries of 18F fluoride plus 15 millicuries 18F FDG, a 1-to-3 ratio, for the combined scan. For 15% of the patients, an injection of 15 millicuries 18F FDG, then an average of 2.2-hour delay, followed by a 5 millicurie injection of 18F fluoride for the combined scan. Oral and IV contrast agents were used on 18F FDG whole body scans only. Here are the trial results. In 15 of the 62 patients, or 24%, neither the 18F FDG whole body PET-CT scan nor the combined 18F fluoride and 18F FDG PET-CT scan identified malignancy. In the remaining 47 patients who had PET findings of malignancy, a greater number of lesions were detected in 16 of 47 patients, or 34%. This was found by using the combined 18F fluoride bone scan and 18F FDG whole body PET-CT scan, compared to the 18F FDG only PET-CT whole body scan. In 2 out of the 47 patients, or 4%, the 18F FDG only scan demonstrated soft tissue lesions that were not really identified on the combined study. In 29 of these 47 patients, or 62%, the combined scan detected an equal number of lesions compared to the 18F FDG-only whole-body scan. Subgroup analysis showed no significant differences between combined scans done by simultaneous versus subsequent injections in terms of changing the overall impression or staging of the patient. Overall, 60 of the 62 patients, or 97%, showed an equal or greater number of lesions on the combined scan than on the 18F FDG only whole body scan. Here are some images from the International Prospective trial. This is the case of a 32-year-old male patient with rectal cancer referred for restaging. Images A and B are MIP PET images. Image B was obtained after combined 18F and 18F FDG administration. It demonstrates focally increased uptake compatible with L1 osseous metastasis, marked by the arrow. That is not clearly identified on the image from the 18F FDG only whole body scan, which is image A. Image C, a transaxial CT image, shows a sclerotic lesion in the L1 vertebra, marked by the arrowhead. Image D, the PET image from the combined scan, shows increased radiopharmaceutical uptake, marked again by the arrowhead. Image E shows the same lesion area, marked by the arrowhead, which did not show uptake on the 18F FDG only scan. This is the case of a 52-year-old female with breast cancer, referred for subsequent treatment strategy because of detection of suspected recurrence. Images A and B are MIP images. Image B was obtained after combined 18F and 18F FDG administration. It demonstrates multiple foci of increased uptake compatible with osseous metastasis that are not clearly identified on the image from the 18F FDG only whole body scan, which is image A. Image C through E are of transaxial images of selected lesions marked by arrowheads in the L4 vertebra, left sacrum, and left femur. Image C is a CT image. Image D is 18F FDG only whole body PET, and image E is combined 18F fluoride and 18F FDG PET. As you can see, the lesions are more prominent on the combined scan. Continuing with the international trial images, as you may recall, in 2 of the 47 patients who had PET findings of malignancy, the 18F FDG only whole body scan demonstrated lesions that were not identified on the combined PET-CT scan. The next 2 slides show these results. This slide shows the images of a 59-year-old female with breast cancer referred for subsequent treatment strategy for detection of suspected recurrence. The top row consists of 18F FDG only whole body PET-CT, transaxial CT, PET, and fused PET-CT images. This row shows uptake in the mediastinal lymph nodes, marked by arrowheads. The bottom row shows a combined 18F FDG and 18F fluoride PET-CT scan, with corresponding CT, PET, and fused images, showing very mild uptake in the mediastinal lymph nodes, marked by the arrowheads. This is the case of a 70-year-old male with prostate cancer referred for subsequent treatment strategy. The top row images are from the 18F FDG only whole body PET-CT scan, with transaxial CT, PET, and fused PET-CT shown. This row shows uptake in retroperitoneal lymph nodes, marked by arrows. The bottom row images are of a combined 18F FDG whole body and 18F fluoride PET-CT bone scan. Corresponding CT, PET, and fused images show very mild uptake in retroperitoneal lymph nodes, marked by the arrows. Liver lesions, marked by the arrowheads, are apparent in both scans. In conclusion, this current study demonstrated that 18F FDG whole body and 18F fluoride bone scans can be combined in a single PET-CT scan by administering the two radiopharmaceuticals simultaneously or in sequence on the same day. This allows for improved patient convenience and reduced radiation exposure from the CT component. The combined 18F FDG whole body and 18F fluoride PET-CT bone scan appeared to increase the sensitivity for detection of osseous lesions compared to the 18F FDG only PET-CT whole body scan in the studied population. Further research is needed to identify and validate the specific indications of the combined 18F FDG whole body and 18F fluoride PET-CT bone scan. The potential reduction in healthcare costs should also be further evaluated. It is possible that other tracer cocktails may be of even greater clinical value, as the combination of PET radiopharmaceuticals for a single examination continues to evolve in the future. Let's now take a look at the University of Missouri follow-on cocktail ratio study. As you remember, the Stanford University human study used a ratio of 1:3 of 18F fluoride to 18F FDG. In 2011, the University of Missouri studied the use of various ratios on mice. The tested ratios of 18F fluoride to 18F FDG were 3:1, 1:1, 1:3, and 1:5. The researchers concluded the optimum combination of 18F fluoride to 18F FDG was achieved as the ratio approached 1:5. Resulting micro-PET images showed soft tissue and bone delineation nearly identical to single-agent scans. The preclinical assessment of 1:3 and 1:5 ratios are continuing. The next two slides show the sources used in the preparation of this webinar. Thank you for joining us today, and we hope you enjoyed our webinar presentation. Please remember to take your test and that you must score an 80% or above in order to receive your certificate.